Well, thank you. And for a change, no slides. Because I think that death is too important subject to be captured in the confines of a PowerPoint slide. Death cannot be killed by bullet points. So let me talk to you face to face, eye to eye, heart to heart. 2026. And exactly 100 years ago, my mother was born in 1926. Those were the days when the two most important milestones in life, birth and death, occurred always at home, never in the hospitals. That was the time the obstetricians were not born. That was the time intensivist as a breed was unheard of. That was the time the super specialization as a adjective did not arrive in English language. So like millions of people all over the world, my mother was also delivered at home. And we, all six of us, also had a fortune of being delivered at home. In 1973, I came to Nagpur, to GMC Nagpur, and today I find in the audience several of my friends, Suresh Batra, Avinash Deshmukh, Ramesh Mundle, Bhatkule, Dr. Ganzre, there, isn't it? And when we were doing our residency in the late 70s and early 80s, well, we also found that death was making a transition from homes to the hospital, but even at that time, the ICUs were not fully functional. And then came an era of mid 80s and early 90s when the ICUs started functioning and proliferating almost all over the country. And suddenly we found that both births and deaths, the two key important milestones in the country, which were confined to the home to begin with, now started transitioning to the hospital. And they transitioned from the hospital general wards to the ICUs. As the ICUs became more equipped, they started beaming with monitors, dialysis machines, intracats, lines, infusion pumps, and ventilators, and so on. I'm not here to deny the importance of ICUs. I'm not here to belittle the huge impact that the ICUs have made to save our lives. They all have. Today, as a physician, I know the wonderful impact the cardiologists have made by snatching the life of a cardiac patient from the tightening jaws of death. I know how the people with ARDS are surviving. We know how the people with severe sepsis are being sent home. We know how the people who are victims of accidents are beautifully, urgently operated by neurosurgeons and start walking again. So there is absolutely nothing to deride the importance of ICUs. But in the process, what we forgot, that the very reasons the ICUs were born, the very reason the intensivists came into being, the very reason the super specialty in the country started proliferating and they started taking care of organ-specific medicine, they were meant for an acute medicine, life-threatening illnesses, where life and death makes a difference. But gradually, these ICUs also started transitioning to the chronic illnesses. And we found that people with severe strokes, people with metastatic end-stage malignancies, patients with end-stage decompensated cirrhosis, portal hypertension, varices, encephalopathy, almost dying there. People with terminal dementia also began to be dumped into the ICU and they started dying there. This was completely unacceptable. Unacceptable for the simple reason that we don't have to ask ourselves that why did it happen? We don't have to read Harrison to figure out where did this change come about. If we go back to 3,000 years back and look at our sacred granthas, Mahabharata, we find the answer. In Mahabharata, the king Yudhishthira was asked a very probing question by the celestial spirit that what is the most wonderful and most surprising thing that you found on this Mother Earth? And his answer was that every day we found countless people dying, and yet each of us think as if I will not be that person. So we consciously started denying death. Look at Mahabharata again, and we find Bhishma Pitamaha on the sage of arrows there, waiting and choosing his own date that I will die after Uttarayan there. And he was not asking for an escalation of care or more infusions or more vasopressors or a ventilator or a dialysis machine. He was fully determined that I am going to die, but I have chosen that my day. You look at Jain mythology and they have got a beautiful concept of Santhara, which is not a suicide, but they abandon their body because they find that their time is up. And the same goes in Quran, the same goes in Bible, where Bible says that everyone is born, everyone also goes away. Which means that birth and death were the two very important milestones in life. In between what was felt was called life, and when the life was about to end, death was not considered as a defeat or a failure, but simply a transition. And this is what exactly Bhagavad Gita also says in chapter 2, shlok 22, where it says, Vasansi jirnani yatha vihai, which means that there is a difference between a body and soul. Soul is eternal, so this body might decay, but soul is eternal, so the soul is transitioning into another new body, it is discarding the old body. But having been witness to this ancient mythological and sacred texts from Mahabharata, from Vedas, from Upanishads, from Jainism, from Buddhism, from Quran, from Bible, in the process we forgot something, that death is not a medical failure, death is not a medical disease to be conquered, death is something not to be painted with negative brush. But then why did we start doing that? Partly because of our medical training. I go back to my medical days in GMC Nagpur, where I spent about 8 or 10 years training myself and then doing a post-graduation in medicine, and think that we had wonderful teachers in GMC. And later, when I spent my 4.5 decades in Sevagram, I had wonderful teachers like Dr. Gupta, Dr. Jain, Ullas Jaju, who taught me so much about medicine there. I was lucky enough, along with Dr. Mundle, to be a student of Dr. B.S. Chaube, who taught us wonderful medicine at that time, isn't it? But while we are taught how to make a diagnosis, how to order an investigation, how to figure out a chaotic arrhythmia, how to read an ABG, and perhaps maybe how to look at that time CTs and MRIs were not there, how to interpret chest X-rays, write prescriptions, predict the future, etc. What we lacked in our training, nobody talked about death. So death was almost a taboo in medical colleges. Nobody would talk about death. It was almost like sex, because it was a taboo. Everybody wanted to know about it, but everybody was afraid of talking about death, because death always carried some negative connotations about it. Death was considered a medical defeat. Somebody is dying, it was supposed that it was a failure. And that perhaps was the reason, if you look at every hospital chart and the final page of a death summary, you would find these lines, hospital after hospital, state after state, country after country. In spite of our best efforts, the lines would read, I quote, in spite of our best efforts, the patient could not be resuscitated and could not be survived and was declared dead. We couldn't succeed. We failed. It is almost Yashasvi Jaiswal saying that Rajasthan Royals lost because I failed. I couldn't succeed. And that line carries through, well, we wanted to conquer death, but we couldn't. Sorry, our apologies. And when the same residents now present a death case in the weekly morbidity and mortality meetings in the hospitals, teachers are there to find out, why did the patient die? You must have made some problem. You must have you must not have read his ECG properly. You missed an arrhythmia. You didn't treat his sepsis. You didn't up his vasopressor. You didn't read his EEG properly. You should have dialyzed him earlier. So the resident there feels as if I have created a tragedy of errors and I was responsible for death. And the trouble is that when the patients are dying, these are not the senior consultants who would come and counsel the families there and pronounce death. Often this task is left to the first year junior PG in the medical colleges, who has absolutely no experience of how to deal with the dying patients, what death is all about, and he has to go and face that angry crowd of patients' relatives waiting outside, Doctor Sahab, ye death kyun ho gayi hai karke. So death, in spite of being treated as a very physiological, very natural process here, creates a great amount of tension, fear, misery, anguish, depression, and irritation. And add to that, nowadays in the last 2 decades, we find there are well-read relatives now who have acquired a Google Gyan or an AI wisdom, so to speak. There is praise, there is media, there is WhatsApp University, there is social media, there are Facebook channels and so on, where every death is dissected and post-mortem almost threadbare. With the result that over the years, we the doctors were never trained how to handle death. We were never at ease of how to accept death, and in the process we did not also educate the society at large that how death is not a defeat, death is not a failure, but death is something very natural. Everyone who comes today on this mother planet ultimately had to leave this planet. Some leave it early, some leave it dead, and some suffer, some are lucky not to suffer, and so on. So this professional pride and this professional fear now creates a huge problems so far as the death is concerned. And then there is another problem. Where do you die, isn't it? And from my own experience, I find that broadly speaking, your death is geographically determined. One, you are very rich, you are very famous, you are well connected, you are more likely to die in a large metropolitan 7-star hospital. Money is not a problem there, isn't it? And you would have extremely rich, very well connected relatives. They would have not single, double or triple, they will have dozens of multiple opinions from all over the world. They would order every investigation possible for that person. They will order the most expensive and most innovative therapy ever available on this mother planet, and that person would die a very ugly, lonely, technical death in an ICU, intubated, ventilated, with a central line in, with a nasogastric tube, with a percutaneous gastrotomy, a CVP line, a hemodialysis shunt there, and with his entire body being crisscrossed by catheters, and he dies a very lonely death. When he or she dies, there is nobody around. For the simple reason that most expensive ICUs in this country and all over the world, the relatives and the loved ones and the spouses and children are separated from the dying patients by thick, beautiful glass panes, by a visiting hours board, and a चौकीदार in नीली वर्दी would say, sorry, you are not allowed in. मैं कई बार सोचता हूँ कि हम विदर्भ एक्सप्रेस से वर्धा से बम्बई जाते हैं 2 दिन के लिए, और स्टेशन पर हमको 4 लोग छोड़ने आते हैं कि 2 दिन बाद ही वापस आने वाले हैं। और यहाँ तो मैं दुनिया छोड़ रहा हूँ, यहाँ तो मैं इस दुनिया को छोड़ रहा हूँ, लेकिन जब वो दुनिया छोड़ने के जब क्षण आए हैं, उस समय तो मेरे परिवार का कोई पास में नहीं है, वो सब तो बाहर है। And what do we deliver them? We deliver them a dead body wrapped in a white sheet on a stretcher, crisscrossing the convoluted corridors of the hospital. And that white sheet still sends shudders to my spine, isn't it? Because to see a dead body in a white sheet and that spouse not being allowed to enter the ICU and not being allowed to hold the patient's hand, and suffering a lifelong guilt that, well, I couldn't be with my husband when he left the world, is something which we cannot understand here. The second scenario is how the middle class in the country dies. And this is true for small towns like Wardha, Chandrapur, Gondia, Amravati, Buldhana, isn't it? In almost every of these towns, you would find that there are ailing parents. They are 80 plus. Their children are in Mumbai or Pune or Bangalore or Hyderabad or Dubai or Singapore or US. Now they fall ill, isn't it? And the son, and I don't want to instill a guilt in the son or a daughter-in-law. Sorry, I cannot come to see my father who has a terminal stroke every month in Wardha. I cannot. Even if I want, I cannot, isn't it? So there are now video conferences with those children. There is a daughter in California who would call the doctor morning and evening and would start giving her sermons, that this should be done, this should not have been done. She would start finding fault in everyone, and ultimately this person also dies in the ICU, again a lonely technical death. And there is a third category which I see every day in Sevagram, where we look for socially marginalized people, who are poor people, who are not literate, who come from lower socio-economic strata, isn't it? And many of them also suffer, as the human beings would do, with a chronic incurable diseases where their life is very limited. And who these people are? They're the chronic alcoholics who have got decompensated cirrhosis, portal hypertension, varices, and encephalopathy. They're the people who have got terminal respiratory failure. They're fighting with these COPDs. They are the people whose creatinine has gone to 22 and 24. They are severely acidotic. They are bloated all over. They are bleeding from their guts, and they have no money in their pocket. They are the victims of a roadside accident who spent about a month or so in a Nagpur neurosurgery center, have completely lost all their money. They are still in GCS 3. They are completely leading a vegetable life, and now they come to Sevagram saying that, well, we have been abandoned. And we have people with metastatic terminal cancers, isn't it, whose life is limited. And wherever they go, the doctors say, ki nahi bhai, ab to kuch nahi kar sakte. They are not seen by their primary care physicians because say that you have got a cancer, sorry, we cannot deal it. The district hospitals rub up their hands saying that, well, you go to the next center. The medical colleges don't admit. The surgeon says that you are beyond surgery. The radiotherapist says that I cannot radiate you. The chemotherapist says that you are too weak to undergo another session of a chemotherapy. So they, at every stage in their life cycle, they feel abandoned, and they ask me that, where should I go? If nobody is willing to take me in and all doctors are abandoning me, then what do I do? What do I do with my breathlessness, with my edema? I am not able to eat. I throw up almost everything. I feel so tired. I feel sleepless. My body aches. What do I do then, isn't it? Where did your modern medicine come in to take care of me? And this creates more and more problems. In fact, in Sevagram a couple of years back, we called a wonderful oncologist and a palliative care physician from Australia, Dr. Sankha Mitra, who is a Bengali. And he said a wonderful sentence which still resonates in my mind. He said that in India, the poor die in agony in neglect. The middle class dies in agony in ignorance. And the rich die in agony on ventilator. Nobody dies a peaceful death. Nobody dies a dignified death. Nobody dies a death that he or she wants. So then what is the solution, isn't it? I have painted a very grim picture here of what is happening to the death in our country, but then what is the picture? And a couple of years back, I had a chance meeting with Dr. M.R. Rajagopal, who is the father of palliative care medicine in India and was awarded Padma Shri for his wonderful work in Kerala. And Kerala model in palliative care medicine is talked all over the world for the way they have dignified death, the way they have offered the palliative therapy to patients with a variety of incurable diseases. And a chance meeting with Dr. Rajagopal motivated me to start a palliative care unit in Sevagram also. So we built a hospital in Sevagram, a 30-bed palliative care unit where we admit patients with all the diseases that I encountered just now. It is not only cancers, but there are terminal cirrhotics, renal failures, dementias, bad strokes, failing hearts, malfunctioning kidneys, lungs, and road traffic accident, and so on. And every day I wear as a physician 2 hats. First, I start my rounds in the ICU where everything is action, cut, isn't it? You have to take split-second decisions. Here a patient has come with an acute ST-elevated MI, they are just 35 minutes. Well, the cardiologist is available, the primary angioplasty, I will take some 3 or 4 minutes. Yeah. So, yeah. So, and so on. So we have to take split-second decisions. And after taking rounds from the ICU, my residents and I, many of my residents are sitting in the audience today, isn't it? We take a round of a palliative care. And what do? In the palliative care, quote unquote, we do nothing. All that we do is that there are patients lying on the bed. We have also provided a special bed to the patient's relatives and caregiver so that they can sleep comfortably in the night just by the side of their patient. We have created a unit which is completely open here, where in the morning they can just open the windows and see the sky, see the moon, see the light, see the rain, see the Vidarbha Express going by. We have morning and evening prayers in the palliative care unit, and we have also placed a television where they can see the IPL matches also. So everything that is not allowed in the ICU or wards of the hospital is deliberately allowed. Whatever you want to do, you can do. And when we go to the rounds with them, well, we don't look at their CT scans or the next lesion on the pate, or saying that there is another 1 centimeter nodule over the liver, which is a new development, or this enzyme has gone up, and so on. We have already seen those files before. So what we do, my residents and I, and my colleagues, we just pull out a chair, sit by the patient, we hold their hands, isn't it, look in their eyes, and let their stories unfold themselves. And there they tell their stories. They tell their stories of frequent visits to the different hospitals, that they have completely drained their money, there's probably nothing in the life left, they have got fear, they have got some expectations, they have some unfulfilled desires, plans, some want to go to do a Char Dham Yatra, some wants to see the granddaughter's son, some wants to see the son getting married, some has some unfulfilled debts to be paid, and so on. We silently listen to them, isn't it? And as we listen to them, we also do something which has never been done before. We start talking about death. We tell them that you are dying. There is no point in telling a truth and telling a lie and telling them that, well, we are still hopeful, let us try one more thing, and we say, sorry, your time is up, probably you are dying. We don't know. This could be few weeks, this could be few months, we don't know, but you are probably dying. Every day you are dying. So we prepare them for that ultimate death there. We prepare the relatives for the ultimate bitter truth which they want to hear, but pretend that they don't want to hear that. We also, and in the process, we let our patients die. There are no monitors in our palliative care unit. There are no defibrillators. There are no ABG machines. There are no infusion pumps. So the people die peacefully, surrounded by their own relatives. And every day we see that there is a woman there, and her granddaughter is massaging her feet, that her son is feeding her, that her husband is reciting some sacred shlokas or mantras here, and the person no longer feels lonely, but surrounded by their own loved ones and relatives, and ultimately they die. During this process, several of my residents cry. Yes, the doctors cry. As a profession, we are supposed not to cry. We are supposed to have a stoic personality, isn't it? We are supposed to bottle up our own emotions here. But many of my residents actually cry. And why do they cry? They cry because they remember their father or grandfather who died a very painful, ugly, isolated, technical death in ICU, where he or she was not able to see the grandfather and was not allowed to be with the grandfather, and ultimately what she got was a dead body. She feels that there are several things which should not have been done. There are several futile therapies in the ICUs which should not have been offered. There are several interventions which should not have been done. But because of probably social pressures, culture, society, money, guilt, etc., they had to do. And they wish, how we wish today that we should not have done that. That is often a cathartic experience for my residents. And I feel very proud. I feel very humbled. I feel very satisfied when they cry, isn't it? Because those palliative care days and those trysts with the patients teach them something which we cannot teach them in our classrooms or seminar rooms or crowded ICUs or in the OPDs. We teach them science, we teach them modern technology, we teach them interventions, diagnostics, and AI. But this is something which we normally do not teach. Here they learn from the patients. I, for one, has learned so much from my patients. I still remember one of my patients, a 40-year-old woman with a bad esophageal cancer who was reduced to just 22 kgs, extremely frail and not being able to eat. For the last 20 years, she and her husband were regular visitors to Pandharpur. They were Varkaris. And when we had some difficulty telling her that she was dying, she held my hand saying that, sir, don't be afraid of talking about death. तो विठ्ठल आहे तुम्हाला बोलावतो आहे आणि मला त्या मरणाची अजिबातच भीती नाही आहे. ज्या दिवशी तो बोलावेल त्या दिवशी मी चालली जाईल. तुम्ही तुमचं काम करा, विठ्ठल त्याचं काम करतो आहे. Now this kind of a spiritualism, this kind of an ultimate philosophy doesn't come from rich and famous and connected people who have got all the powers in the world, but this comes from barely literate, rural, socially deprived and very poor people this comes from a religion, this comes from spiritualism, this comes from their very different attitude to health and disease, to life and death, isn't it? I would like to end by telling you my one more experience today. Dr. Ramesh Mundle is here, and therefore I would like to take him down memory lane. In 1983, very close to Wardha and Nagpur, there is Pavanar. And in Pavanar, Vinobaji lived, Vinoba Bhave, isn't it? He was 83-year-old, and suddenly he became breathless. He started coughing, had some chest pain. Dr. Chaube was called, and they made a diagnosis at that time only with an ECG machine. Even his X-ray was not available that time, that probably he had a pneumonia or a failed heart and some atrial fibrillation or perhaps some pulmonary embolism. Dr. Ashwin Mehta flew from Bombay as cardiologist and said that probably this is a pulmonary embolism, and his treatment was started. After 3 days, Vinobaji stopped treatment, stopped food, stopped liquid, stopped water, and for the next 9 days, Ramesh and I, very young lecturers in medicine at that time, were posted in Sevagram, and in between twice Prime Minister Indira Gandhi came to see Vinoba Bhave. She sat cross-legged on the floor at the feet of Vinoba Bhave. She had tears in her eyes when she left Vinobaji's room, isn't it? And when I, as a very young lecturer, mustered enough courage to ask to the Prime Minister of India, ma'am, Vinobaji has said no to food, water and medicine. As a doctor, is it ethical for me to let my patient die like this? The Prime Minister of the country, that time in 1983, closed her eyes for about 15 seconds, introspected, thought over and said, young doctor, after all, it is his body. He can decide whether he wants to live or die. Who are we, the ordinary mortals, to interfere with his own decisions? Whatever he has decided, stick for that. And this is exactly how 10 days later, Vinobaji died on the day of Diwali, 1983. And believe me, there is I am not at all using a single hyperbole here. I have never seen in my life the more glorious, the more serene, the more spiritual, the more beautiful, and the more calm death than Vinobaji died. There was absolutely no pain, misery, breathlessness, terminal gasping. He simply closed his eyes as if he was waiting for that Diwali day and simply passed away, isn't it? And contrast this death with a former Prime Minister of the country who I do not want to name, but you will all figure it out, who at the age of 93, having had a dementia for almost 10 years, which completely robbed him of his intelligence, of his brain, of his cerebral power, of his beautiful articulation, isn't it? After 10 years of a dementia, bad dementia, where he was confined to his home, could barely recognize anyone, could barely talk, could not eat properly, had to be dependent on all activities of daily living on the hospital staff. When he fell ill, was admitted to AIIMS Delhi and spent the last 6 weeks of his life in AIIMS Delhi ICU and underwent almost every possible intervention available in AIIMS at that time, including ECMO. Why did this former Prime Minister had to undergo all these rituals in the ICU? Why didn't let them die peacefully, isn't it? Knowing fully well that his time was up and he was about to go. But the Prime Minister also had to die because he was famous, he was rich, he was well connected, there was pressure from politicians, social media, almost everyone. So ultimately, even Prime Minister was not also offered a serene, peaceful death. So my final point is that it is up to us, we the doctors, to decide how do we want to die. And the problem is that when our time would come, we would also be probably in the ICU. We might not be conscious, we would not be able to speak, isn't it? And we were not able to decide that how we are going to go. Fortunately, the Supreme Court of India has come to our rescue. After that infamous Aruna Shanbag case, when the 24-year-old staff nurse from KM Hospital was sexually molested and strangulated in KEM, Bombay in 1973, and went on to live for another 42 years, and when a social journalist went to the Supreme Court asking for a euthanasia in 2011 and was not permitted in 20, and then she died a couple of years after, isn't it? In 2018, the Supreme Court accepted and for the first time in our country made euthanasia legal. But still it was difficult to write an advanced medical directive or a living will. A year back, now the Supreme Court has completely made the living will and advanced medical directive very simple. All that you need to write with your own hands, that should there come a day when I am not conscious, or I am terminally ill, or I am unlikely to be salvageable, or the life is not worth living, then maybe I do not want to undergo these, and the list could include intubation, ventilation, dialysis, life support system, more chemotherapies, more radiation, surgery, blah, 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 and I should be allowed to die. This is called living will. This is called advanced medical directive. Let me ask the audience, how many of us have written our own living wills or advanced medical directives, and how many of us are today, even today, prepared to die that painful, lonely, technical, ugly death in the ICU if the time comes? So the time has come, and I would wrap up my already overboard lecture with this, that the time has come today that we all the doctors, write our own living wills, our own advanced medical directives, educate our patients, isn't it? Also ask them to write their living wills, so that then we will not be afraid of a law hanging over us. Well, you killed the patient, this was not legal, and this was not moral, and so on. And if we do that, well, we would be probably countrywide, we would be sparing hundreds of thousands of people from dying from ugly deaths, and would probably offer them a beautiful death. Thank you.
Thank you, sir. Thank you for enlightening us on some different topic. Thank you, sir. Thank you very much.
Thank you, Dr. Kalantri, sir. It's wonderful to listen to you. I have opportunity to listen a lot many times. Along with me, Dr. Manish Pathak, Dr. Chauhan, Dr. Diya Agarwal are here. Our teachers, like our senior teachers, like you already taught us, that explain to the relatives that nothing can be done. Give an option to the relatives, you can take the patient home also. That times in 1980s, we were told, explain that nothing can be done. By admitting the patient, you are not only torturing, you are leaving opportunity for the other who need. Because I am practicing in Wardha, I know that if I am sending such type of patient, those who are needy may not get bed. So if this is the thing, but still because of ethical issue, I explained to the relatives that nothing can be done. You can take the patient home, but on my referral it is written, refer the patient to MDMS for further management. So can anything be done on ethical ground that such opportunity should be given to this kind of patient where I am safe as a doctor that no legal issues will come to?
Yeah, I would like to answer this question by saying this, that as a profession, unfortunately, we have lost that trust today. Gone are the days when the doctors were supposed to be the friend, philosophers, and guides to the families. Unfortunately, we have lost that position today. So if we regain that trust in the society and always start acting in the best interest of a patient and give them a proper advice, then I think the most families are willing to listen to that, isn't it? है ना, वो भी अपने मन से यही चाहते हैं, लेकिन आपके मुंह से बुलवाना चाहते हैं, और आप कहते हैं तो वो उसमें से 90% लोग सुनेंगे. और ये बात तो देखिए कि समाज में आप 5%, 10% लोग हैं, आप कुछ भी करिए, they will be hostile, they will turn against you, might sue you in the court of law, whatever you do, isn't it? You do. But perhaps that fear of being sued, perhaps those legal consequences, etc., should not deter you from at least explaining to the people. And one more thing, that don't use the word nothing can be done. जैसे हम कहते हैं ना, no, nothing can be done, पेशेंट के मन में और पेशेंट के परिवार के मन में घोर निराशा आने लगती कि अब कुछ भी नहीं बचा है, अभी भी हम हैं आप. द मोस्ट इंपॉर्टेंट थिंग इज दैट वी आर नॉट अबंडनिंग यू, हम भी अभी आपके साथ में हैं, isn't it? And we would be there till the end comes. So we are not abandoning you, but now we are not adding years to your life, but life to your years now. तो आपके जो पेन्स हैं, नोजिया है, वॉमिटिंग है, असाइटिस है, प्लूरल इफ्यूजन्स हैं, जो भी है, उन तकलीफ़ों को कम करने का प्रयास करें ताकि आपका जो अंतिम प्रवास है वो सुखद हो, आपकी जो मृत्यू है वो सहन करने लायक हो. हम आपको छोड़ नहीं रहे हैं. सेवाग्राम में हमेशा पेशंट्स यही आहेत की डॉक्टर साहेब आम्ही कुठे जायचं. सगळे म्हणतात की आमची केस नाही आता, तुम्ही तिकडे जा, तिकडे जा, तिकडे जा, तिकडे जा. आमचा सर्जन आमचा ऐकत नाही, आमचा रेडिओथेरपी म्हणते मला आता लाईट द्यायचे नाही, किमोथेरपी म्हणते लाईटच्या तू बियॉन्ड गेलेला आहेस, मेडिसिनवाले ॲडमिट करत नाही, कॅज्युअल्टीवाले हाकलून लावतात, मी जायचं कुठे. आणि मोठ्या हॉस्पिटलमध्ये जाण्यासाठी माझ्याजवळ पैसा राहिला नाही आहे, आता मी जायचं कसे. हाऊ आय विश वी कुड हॅव दॅट M.R. Rajgopal's Kerala model in Maharashtra as well, where they are doing a beautiful work by now dehospitalizing terminal care. Now the people with terminal care are no longer admitted to the hospital, but their team of social workers and nurses actually pay visit to the patients in their homes and do whatever is possible in their homes also. They also change their nasogastric tube, change their urinary catheter, give them their weekly or monthly supply of morphine tablets and so on. So most of the people in Kerala now die at home, not in the hospital. So what Dr. Rajgopal did in Kerala is absolutely phenomenal. So it is high time that we also learn the Kerala model and try to bring it in the mainstream of medicine.
Just a little faster. Sir, excellent lecture, sir. Kalantri, sir. With all due respect, I'm almost like I didn't match. Your experience is more than my age. But still you used one word like ICU deaths are all, bad deaths, or it's like undignified deaths. But even ICU deaths or hospital deaths are dignified deaths. Whether it is dignity or not, all comes from the patient's perspective or the family's perspective. We in ICU always, day in and day out, to try to respect the patient's will. Not only patients, the family will too. But again, the question comes with all the medical principles, whether you have offered the treatment, everything is there in the book or not, or whether you didn't offer the treatment. As Sir rightly asked, everything, you cannot do anything, but they go back and come back and say, you can try dialysis for these patients. So again, you'll be in a land of, junction of 4 roads to decide it off. So it's the trust of doctor, trust of the attenders that decides the dignity, that decides the place of the death, that decides, the outcomes of the patients. Even if they write a willing will, like the living will is mentioned. So if the will is there, for example, a 70-year-old comes to my ICU with acute dehydration, gastroenteritis and shock. Because will is there, I cannot leave him because the chances of survival are 90% there if I just treat him with IV fluids. And I cannot say that I can't place central line because your will is there and all. So as a doctor, I feel give them the options, let them choose the options. It's all their choosing, it's all their choice, where to die, how to die, and then whether dignity is there or not, it's not my job. It's the family's job to decide it off. Correct me if I'm wrong, sir, please.
You are absolutely right, and see, death is a subject on which nobody is right and nobody is wrong. We cannot paint death right and black. There are always shades of gray here, isn't it? So it all depends on how you take your life, what are your views, how aggressive you are, how permissive you are, how spiritual you are, how religious you are, how with the age you have mellowed down or not, what is your own experience, and so on. So I don't think that in a very complex issue like death, nobody is right and nobody is right. Every view is important. I respect every individual viewpoint there, and so on. So Dr. Avinash Deshmukh, he is here, my classmate and ENT surgeon here, and he had a good fortune of having lived with Dr. Manu Kothari. And Manu Kothari has written a book called Death, isn't it? And Manu Kothari has come to Nagpur on so many occasions and has lectured so often, isn't it? And is one of the most wonderful speakers we all have seen, isn't it? And if you look, if you read his views on life and death, isn't it? They make a very wonderful reading. In fact, in our palliative care unit, sometimes I open my Kindle, isn't it, and read with the residents Atul Gawande and Ranjana Srivastav. Atul Gawande's wonderful book, Being Mortal, is a book which every doctor must read. Every doctor must read. Ranjana Srivastav is an Australia-based oncologist and a palliative physician who describes wonderfully well what life and death and terminal evening of life is all about, isn't it? Our own Dr. Manu Kothari is a legend who has demystified death. And see that Dr. Manu Kothari was lucky to die exactly the way he preached all his life. He just died. He just died in his home, surrounded by his loved ones, isn't it? So there are very few people who are so lucky to die like this. But then मैं कई बार सोचता हूँ कि हम मेडिसिन में हम हैरिसन पढ़ाते हैं और ब्रॉनवॉल्ड पढ़ाते हैं, हर्स्ट पढ़ाते हैं, शीला शेरलॉक पढ़ाते हैं, लेकिन ये बातें तो कोई नहीं पढ़ाता नहीं। और अंत में जीवन में तो यही बातें काम में आती है उस पेशेंट्स के लिए। तो शायद इन चीज़ों को भी हमारे मेडिकल करिकुलम में उसका समावेश करना चाहिए। थैंक यू।